you can relax this leg out like this. From a position point of view, what I will tend to do is treat the knee in this flex position because it allows me good access, but I can also have, in terms of what I want to do, is palpate and feel my surface anatomy and make some marks in terms of some of these areas that we want to treat. So in this case, if our patient, for example, has some medial compartment osteoarthritis, I'm going to treat some of the effectively some of the structures around the joint, but we can also use a deeper standoff to treat bone marrow edema if in the circumstance where we've got an MRI and we're seeing that one of the big pain drivers is significant bone marrow edema in this patient. So I'm feeling through here, I can feel my joint line through there, marking that. Now I'm going to feel down around that pes anserine insertion and that insertion of our medial collateral ligament, and I can make some marks where there's some tender areas. Feeling up around the medial femoral condyle. And again, we might have some areas that are tender. We've got our genicular nerve sitting just behind that femoral condyle, which we can make a bit of a mark. We can also treat the synovium as well, which we know in osteoarthritis can be a pain generator as well. So we know that cartilage itself is effectively aneural. It doesn't have a nerve supply, so wear and tear of cartilage is not necessarily painful, but the consequence of higher loads on the subchondral bone in more advanced cases can cause bone marrow edema, which can be very uncomfortable. And we can often get some synovitis around the capsule, which we want to treat at the same time as well. So once I've marked out, I'm going to move over, and we're first going to treat some of those structures outside the joint capsule. So I'm going to use a superficial standoff, just as we did for the Achilles tendon and the plantar fascia. Okay. Fantastic. So we've got our device ready to go. I'm going to again start off in an area. I'm going to start off just over our VMO through here. So we're in muscle. Marco's not going to feel much through here, and I'm going to slowly start to work down towards that medial femoral condyle. How are you feeling there? Fine. And we've got that ability to change and increase the energy. And as you're treating and as you're scanning over some of these areas, there are going to be points where the patient doesn't feel much at all. And then there's going to be points that are more reactive. And that can be an indication that they're pain generators. And we can spend more time focusing to try and decrease some of that neurogenic inflammation. Start now treating down through our medial collateral ligament, through the medial meniscus. Yep, got a little bit more tenderness down there, and we can start treating through that joint line as well and treating some of the synovium. So the way I tend to treat is we're almost effectively making some relatively small movements with our handpiece, and we're going to find those areas that are more reactive. And once we find those areas, we're effectively going to slow down and we're going to treat those areas until the pain starts to dissipate. And then I'm going to move on to another area. The other thing that's really important as well is when we're treating when we've got osteoarthritis in a joint, we're often going to have some dysfunction of the muscles that control that joint. And this is where our radial comes into use. So once I've treated those areas with the focused, I'm now going to swap over to my radial device and I'm going to treat through the quadriceps muscles because we've often will have some atrophy or some deactivation of some of those muscles. So we want to effectively get that whole joint moving, and part of that is switching the muscles back on as well. So again, I'm going to use a relatively high frequency of 25 through here. We're going to start our shockwave, and I'm going to effectively start working through some of these areas. And as you're treating, once again, you're going to find more reactive points within the muscle, and we're going to spend some more time on those. It's always really important to stabilize the area that you're treating as well. So you can sort of see with one hand, I'm stabilizing, and I'm also relatively stable with how I'm holding the applicator tip. With our radial device, we've got the ability to deliver a higher frequency. So it means that we can treat large areas in a relatively short period of time. You start to feel, there we go. So we're working up now through our sartorius muscle through here. So I generally use firm oppression on that downward strike and a bit less pressure on the way up. So I'm working through that area. And again, we can treat up through our quadriceps tendon through there. And now I'm going to move over to our vastus lateralis. And treating the fascial connections to our knee joint as well. So with that higher frequency, what it allows us to do is to treat relatively big muscle groups and deliver a high amount of energy. So one of the unique things and one of the reasons I use the DolorClast device is we effectively get high energy output at those higher frequencies. So with traditional first generation handpieces, as the frequency increases, we get a drop off in the energy. So it means that when you're treating at those higher frequencies, we often get less energy delivered to the tissue.